Reproductive health is a fundamental component of primary care. As a family nurse practitioner, you are on the front lines, addressing sensitive and critical health issues that span a patient's entire life. From managing common infections to identifying life-threatening malignancies, your expertise is vital. A thorough understanding of the reproductive system is not just about passing your certification exam, it is about providing competent, compassionate, and comprehensive care to your patients. This knowledge empowers you to make accurate diagnoses, initiate appropriate treatments, and recognize when a patient requires a higher level of care. Mastering this area ensures you can confidently handle the diverse patient presentations that will walk through your clinic doors daily. The scope of reproductive health in a family practice setting is incredibly broad. You will encounter issues ranging from benign conditions that affect quality of life to insidious diseases that require urgent intervention. Patients will present with concerns about sexually transmitted infections, urinary difficulties, pelvic pain, sexual dysfunction, and cancer risks. Your role involves not only treating the presenting problem, but also providing essential education, screening, and preventative care. Building a strong foundation in the pathophysiology, diagnosis, and management of these conditions is non-negotiable for the aspiring and practicing family nurse practitioner. It is the bedrock upon which trust and positive patient outcomes are built in the primary care relationship. This essay will serve as a focused guide to some of the most high-yield reproductive system topics you will encounter on the family nurse practitioner exam and in clinical practice. We will systematically explore common male reproductive health issues, including sexually transmitted infections, benign prostatic hyperplasia, prostatitis, epididymitis, erectile dysfunction, and prostate cancer. For each condition, we will break down the essential information you need to know: how to identify it, how to treat it, and crucially, how to recognize the warning signs that signal a need for immediate action. The goal is to equip you with clear, practical knowledge that translates directly into clinical confidence and competence. Think of this material as a clinical toolkit. Each section is designed to provide you with the necessary instruments for effective patient management. We will delve into clinical pearls, those invaluable bits of wisdom gained through experience, that can help you navigate diagnostic gray areas and avoid common pitfalls. Furthermore, we will explicitly define the danger zones, those critical scenarios where a delayed or incorrect action could lead to significant harm. By understanding these key concepts, you will be better prepared to not only succeed on your certification exam, but also to excel as a safe and effective provider in the complex world of family practice. Sexually transmitted infections are a group of infections passed primarily through sexual contact. As a family nurse practitioner, you will be diagnosing and managing these conditions frequently. The most common bacterial sexually transmitted infections include chlamydia, gonorrhea, and syphilis, while viral infections like herpes simplex virus and human papillomavirus are also prevalent. Diagnosis often begins with a thorough sexual history and a physical examination. For chlamydia and gonorrhea, nucleic acid amplification tests on urine or swab samples are the gold standard. Syphilis is diagnosed through serological tests like RPR or VDRL, confirmed with treponymal tests. Herpes simplex virus is often diagnosed clinically, but can be confirmed with a viral culture or PCR of a lesion. Treatment for sexually transmitted infections must be prompt and targeted to prevent complications and further transmission. For uncomplicated chlamydia, the standard treatment is a single 1-gram dose of azithromycin or a 7-day course of doxycycline, 100 milligrams twice daily. Uncomplicated gonorrhea is treated with a single 500 milligram intramuscular dose of ceftriaxone. It is crucial to co-treat for chlamydia if it has not been ruled out, though this practice is evolving. Primary, secondary, or early latent syphilis is treated with a single dose of benzathine penicillin G, 2.4 million units intramuscularly. Management of viral infections like herpes focuses on symptomatic relief and reducing transmission with antiviral medications, such as acyclovir, valacyclovir, or famciclovir. A key clinical pearl is to always treat the patient's partners. This practice, known as expedited partner therapy, is legal in most states and is critical for breaking the chain of transmission. For gonorrhea and chlamydia, you can provide a prescription for the patient to give to their partners without an examination. Another pearl is to remember the 5 Ps when taking a sexual history. partners' practices, prevention of pregnancy, protection from sexually transmitted infections, and past history of infections. This structured approach ensures you gather all the necessary information to assess risk and guide testing. Finally, always perform a test of cure for pregnant patients treated for chlamydia and for any patient treated for pharyngeal gonorrhea. The danger zone for sexually transmitted infections involves recognizing complicated infections that require more aggressive management or referral. Pelvic inflammatory disease in females, a complication of chlamydia or gonorrhea, is a major concern. Signs include cervical motion tenderness, uterine tenderness, or adnexal tenderness. These patients may require hospitalization and intravenous antibiotics. Another danger zone is disseminated gonococcal infection, which can present with arthritis, tenosynovitis, and dermatitis. Neurosyphilis is a severe complication of syphilis that can occur at any stage and requires immediate neurologic assessment and intravenous penicillin. Any sexually transmitted infection diagnosis in the context of pregnancy is a high-risk situation requiring careful management to prevent vertical transmission. Benign prostatic hyperplasia is a non-cancerous enlargement of the prostate gland, a common condition in aging men. The enlarged prostate compresses the urethra, leading to lower urinary tract symptoms. These symptoms are categorized into two types: obstructive and irritative. Obstructive symptoms include hesitancy, a weak urinary stream, straining to void, and a sensation of incomplete bladder emptying. Irritative symptoms include urinary frequency, urgency, and nocturia. Diagnosis is based on the clinical presentation, a digital rectal exam revealing a symmetrically enlarged, firm, and non-tender prostate, and a urinalysis to rule out infection or hematuria. The American Urological Association Symptom Index can be used to quantify symptom severity. First-line management for mild benign prostatic hyperplasia often starts with watchful waiting and lifestyle modifications. These include reducing fluid intake before bedtime, avoiding caffeine and alcohol, and timed voiding schedules. For moderate to severe symptoms, medical therapy is initiated. There are two main classes of drugs used. Alpha blockers, such as tamsulosin or terazosin, provide rapid symptom relief by relaxing the smooth muscle of the prostate and bladder neck. 5-alpha reductase inhibitors, such as finasteride or dutasteride, work more slowly by shrinking the prostate gland itself. Combination therapy using a drug from each class is often more effective for men with significantly enlarged prostates. A crucial clinical pearl for benign prostatic hyperplasia management is to check a post-void residual urine volume. A high post-void residual, typically greater than 100 to 150 milliliters, indicates significant urinary retention and may necessitate a urology referral. When prescribing 5-alpha reductase inhibitors like finasteride, remember that they can decrease prostate-specific antigen levels by about 50%. Therefore, you must double the measured value in a man taking one of these medications to get an accurate interpretation for cancer screening purposes. Also, be mindful that alpha blockers can cause hypotension and dizziness, especially the non-selective ones like terazosin, so counsel patients to take the first dose at bedtime. The primary danger zone in benign prostatic hyperplasia is acute urinary retention, a medical emergency. This presents as a sudden and painful inability to urinate. The patient will have a palpable distended bladder and significant suprapubic discomfort. This condition requires immediate bladder decompression via catheterization. Another red flag is the presence of hematuria, which must always be worked up to rule out bladder cancer or other serious pathology. Recurrent urinary tract infections, bladder stones, or signs of renal insufficiency, such as elevated creatinine in a patient with benign prostatic hyperplasia, are also danger zones that warrant an urgent referral to a urologist for further evaluation and potential surgical intervention. Prostatitis is the inflammation or infection of the prostate gland, a condition that can cause significant pain and urinary symptoms. It is broadly classified into 4 categories, but the most common types seen in primary care are acute bacterial prostatitis and chronic bacterial prostatitis. Acute bacterial prostatitis is a severe infection characterized by the abrupt onset of fever, chills, malaise, and significant perineal, suprapubic, or low back pain. Patients also experience urinary symptoms like dysuria, frequency, and urgency. On digital rectal exam, the prostate is exquisitely tender, swollen, and warm. In contrast, chronic bacterial prostatitis presents with more subtle, recurrent symptoms of lower urinary tract symptoms and pelvic pain, often with intermittent urinary tract infections caused by the same organism. Diagnosis of acute bacterial prostatitis is primarily clinical, supported by a urinalysis and urine culture that will show pyuria, bacteriuria, and identify the causative pathogen, most commonly E. coli. A digital rectal exam should be performed very gently, as vigorous massage can induce bacteremia. For chronic bacterial prostatitis, diagnosis can be more challenging. It often requires comparison of pre- and post-prostatic massage urine samples, though this test is less commonly performed now, to localize the bacteria to the prostate. The prostate may feel normal, boggy, or indurated on exam in chronic cases. Prostate-specific antigen levels are often elevated in both acute and chronic prostatitis, but should be rechecked after the inflammation resolves. Treatment for acute bacterial prostatitis requires immediate antibiotic therapy. For a non-toxic appearing patient who can be managed outpatient, a 4 to 6 week course of a fluoroquinolone like ciprofloxacin or levofloxacin or trimethoprim sulfamethoxazole is standard. Treatment for chronic bacterial prostatitis is more difficult due to poor antibiotic penetration into the prostate tissue and often requires a prolonged course of antibiotics, typically 6 to 12 weeks. Fluoroquinolones are often the first choice. Symptomatic relief with alpha blockers to reduce urinary obstruction and NSAIDs for pain and inflammation is also a key part of management for both conditions. A clinical pearl for prostatitis is to always consider it in the differential diagnosis for a man presenting with recurrent urinary tract infections. The prostate can act as a reservoir for bacteria, leading to repeated infections. Another important point is to avoid vigorous prostatic massage during a digital rectal exam in suspected acute bacterial prostatitis to prevent seeding bacteria into the bloodstream and causing sepsis. For patients with chronic pelvic pain syndrome, which is actually the most common type of prostatitis but non-bacterial, management is multimodal and focuses on symptom control, often involving physical therapy, stress management, and medications like alpha blockers or amitriptyline, rather than antibiotics. The clear danger zone for prostatitis is acute bacterial prostatitis, with signs of systemic toxicity, such as high fever, hypotension, or an altered mental state. This suggests sepsis and requires immediate hospitalization for intravenous antibiotics and supportive care. Another danger zone is the development of a prostatic abscess, which should be suspected if a patient with acute prostatitis does not improve with appropriate antibiotic therapy. This complication presents with persistent fever and a fluctuant mass on exam or imaging and requires surgical drainage. Finally, acute urinary retention can occur in severe cases of acute prostatitis and necessitates urgent catheterization, preferably with a suprapubic catheter to avoid urethral trauma. Epididymitis is the inflammation of the epididymis, which is the coiled tube at the back of the testicle that stores and carries sperm. It's actually a pretty common cause of acute scrotal pain in adult men. The condition usually shows up with pain and swelling on just one side of the testicle, and this tends to develop over about 1 to 2 days. Patients might also notice a fever, urethral discharge, or urinary symptoms like pain with urination and increased frequency. A key diagnostic clue here is the Pran sign. Physically lifting the testicle can relieve the pain, although, honestly, this sign isn't always reliable. On physical exam, the epididymis is often tender and feels firm, and the scrotum may look red and swollen. The diagnosis of epididymitis is primarily clinical, but a urinalysis and urine culture should be obtained to check for infection. A urethral swab for NAAT testing for gonorrhea and chlamydia is essential, since these are the most common causes in sexually active men under the age of 35. In older men, or in those who practice insertive anal intercourse, enteric organisms like E. coli are more common culprits. A scrotal ultrasound with Doppler studies is often performed to confirm the diagnosis by showing increased blood flow to the epididymis, and more importantly, to rule out testicular torsion. Torsion is a surgical emergency that can look very similar. Treatment for epididymitis is directed at the likely causative organism and includes antibiotics, scrotal support, ice packs, and pain relievers. For sexually active men younger than 35, treatment should cover gonorrhea and chlamydia. The recommended regimen is a single dose of ceftriaxone 500 mg intramuscularly, plus a 10-day course of doxycycline 100 mg twice daily. For men older than 35, where enteric organisms are more likely, or for those who practice insertive anal sex, a fluoroquinolone such as levofloxacin 500 mg daily for 10 days is the preferred treatment. It's really important to advise the patient to avoid sexual activity until both they and their partners have completed treatment. A vital clinical pearl here is to always have a high index of suspicion for testicular torsion, especially in adolescents and young adults who present with acute scrotal pain. Torsion is characterized by a sudden severe onset of pain, a high-riding testicle with a horizontal lie, and an absent cremasteric reflex. This is a true urological emergency that requires immediate surgical intervention to save the testicle. Another key point is to counsel patients on the importance of scrotal elevation and support, since this can significantly reduce pain and swelling. Bed rest for the first 1 to 2 days is also recommended to help with recovery. The most significant danger zone associated with epididymitis is misdiagnosing testicular torsion. The window for salvaging a torsed testicle is about 6 hours, so any uncertainty really does warrant an immediate emergency department referral and scrotal ultrasound. Other danger zones include complications like a scrotal abscess, testicular infarction, or progression to epididymo-orchitis, which is inflammation of both the epididymis and the testicle. If there's worsening pain, high fever, or increasing swelling despite 48 to 72 hours of appropriate antibiotic therapy, that should prompt an urgent reevaluation and likely a urology consult to rule out these complications. Erectile dysfunction, or ED, is defined as the consistent inability to achieve or maintain an erection sufficient for satisfactory sexual performance. It's, an extremely common condition that can really have significant impacts on a man's quality of life and self-esteem. The causes of ED are multifactorial and can be organic, psychogenic, or a combination of both. Organic causes are actually the most common and include vascular disease, like atherosclerosis or hypertension, neurologic disorders such as diabetes, multiple sclerosis, or spinal cord injury, and hormonal imbalances like low testosterone. Many common medications, such as certain antidepressants and antihypertensives, can also contribute to ED. A thorough medical, social, and sexual history is, honestly, the cornerstone of diagnosis. The diagnostic workup for ED begins with a detailed history to differentiate between organic and psychogenic causes. A gradual onset of ED is more suggestive of an organic cause, while a sudden onset, especially in a younger man, may point to a psychogenic issue. A physical exam should include assessment of blood pressure, peripheral pulses, and neurologic status, as well as an examination of the genitalia for any abnormalities. Basic laboratory tests should include a fasting glucose, or HbA1c, to screen for diabetes, a lipid panel to assess for dyslipidemia, and a morning total testosterone level to rule out hypogonadism. Questionnaires like the Sexual Health Inventory for Men, or SHIM, can help quantify the severity of ED. First-line treatment for ED typically involves oral phosphodiesterase 5 inhibitors such as sildenafil, tadalafil, or vardenafil. These medications work by increasing blood flow to the penis in the presence of sexual stimulation. It is essential to educate patients on the proper use of these drugs. For example, sildenafil should be taken on an empty stomach about an hour before sexual activity. If PDE5 inhibitors are ineffective or contraindicated, other options include vacuum erection devices, intraurethral suppositories like alprostadil, or intracavernosal injections. Lifestyle modifications such as weight loss, exercise, smoking cessation, and reducing alcohol intake are also critical components of management. A key clinical pearl is to view ED as a potential early warning sign of underlying cardiovascular disease. The penile arteries are smaller than the coronary arteries, so they may show signs of atherosclerotic blockage sooner. Therefore, a new diagnosis of ED in a man, especially one with cardiovascular risk factors, should prompt a thorough cardiac risk assessment. Another pearl is to carefully screen for medication-induced ED. Thiazide diuretics, beta blockers, and SSRIs are common culprits. Sometimes, simply switching to a different class of medication can resolve the issue. Always address any underlying psychogenic components, such as performance anxiety or relationship stress, as these can perpetuate the problem even if an organic cause is treated. The most critical danger zone when managing ED is the co-administration of PDE5 inhibitors with nitrates, such as nitroglycerin. This combination is an absolute contraindication, as it can cause a sudden, severe, and potentially fatal drop in blood pressure. Always ask specifically about nitrate use for angina before prescribing a PDE5 inhibitor. Another danger zone is priapism, a prolonged, painful erection lasting more than 4 hours. This is a rare side effect of ED treatments, especially injections, and is a urological emergency requiring immediate medical attention to prevent permanent penile tissue damage. Lastly, be cautious when diagnosing low testosterone as the sole cause of ED. While it can contribute, it is often not the primary driver, and simply replacing testosterone may not resolve the erectile dysfunction. Prostate cancer is, honestly, one of the most common cancers among men. It often grows very slowly and may not cause any symptoms in its early stages. This is why screening is such a critical, albeit controversial topic. When symptoms do occur, they are often similar to those of BPH and can include urinary hesitancy, frequency, a weak stream, and nocturia. More advanced prostate cancer can cause hematuria, bone pain, especially in the back, hips, or pelvis, indicating metastasis, and unexplained weight loss. The primary tools for detection are the digital rectal exam, or DRE, and the prostate-specific antigen, or PSA blood test. On DRE, a cancerous prostate may feel hard, nodular, or asymmetrical. The diagnostic process for suspected prostate cancer begins with an abnormal DRE, or an elevated PSA level. It is important to remember that PSA can be elevated for many reasons other than cancer, including BPH, prostatitis, recent ejaculation, or even vigorous bike riding. There is no single normal PSA value. The level generally increases with age, and the velocity, or rate of change over time, is often more important than a single reading. If cancer is suspected based on these initial findings, the patient should be referred to a urologist. The definitive diagnosis is made via a transrectal ultrasound-guided, or TRUS, biopsy of the prostate gland. The biopsy samples are then graded using the Gleason scoring system. Management of prostate cancer is highly individualized and depends on the stage and grade of the cancer, as well as the patient's age, overall health, and personal preferences. For low-risk localized prostate cancer, especially in older men, a common approach is active surveillance. This involves closely monitoring the cancer with regular PSA tests, DREs, and repeat biopsies, with the intent to treat if there are signs of progression. Definitive treatment options for more aggressive or advanced disease include radical prostatectomy, surgical removal of the prostate, and radiation therapy, either external beam or brachytherapy. Hormonal therapy, or androgen deprivation therapy, is often used for advanced or metastatic disease. A major clinical pearl is the importance of shared decision-making when it comes to prostate cancer screening. The U.S. Preventive Services Task Force recommends that for men aged 55 to 69, the decision to undergo PSA screening should be an individual one, made after a conversation with their clinician about the potential benefits and harms. The harms include false positive results, anxiety, and complications from biopsies and overtreatment of indolent cancers. Another pearl is to know the risk factors. African American men and men with a strong family history of prostate cancer are at higher risk and may need to begin this conversation as early as age 40 or 45. The danger zones for prostate cancer involve recognizing signs of advanced or metastatic disease that require urgent action. The sudden onset of severe back pain in a man with a history of prostate cancer could indicate spinal cord compression from a metastasis, which is a neurologic emergency requiring immediate imaging and intervention. Unexplained weight loss, pathologic fractures, or significant constitutional symptoms should also raise red flags for advanced disease. Another danger zone is failing to refer appropriately. Any man with a confirmed hard nodule on DRE, regardless of his PSA level, requires an urgent urology referral. Similarly, a persistently and significantly elevated or rapidly rising PSA warrants specialist evaluation. As a primary care provider, one of your most critical skills is knowing your limits and recognizing when a patient's condition requires specialist intervention or emergency care. In the realm of reproductive health, these danger zones are situations where a delay in action could lead to irreversible damage, systemic complications, or even death. For any acute scrotal pain, the primary directive is to rule out testicular torsion. The sudden onset of severe pain, a high-riding testis, and an absent cremasteric reflex are classic signs. Do not delay. This is a go to the emergency department immediately scenario, as the window for testicular salvage is only about 6 hours from the onset of symptoms. Another critical danger zone is acute urinary retention. A patient presenting with an inability to urinate, coupled with significant suprapubic pain and a palpable distended bladder, needs immediate bladder decompression. This is not only intensely painful, but can also lead to acute renal failure and permanent bladder damage if not relieved promptly. This requires immediate catheterization, which may be done in the clinic if you are equipped, but often requires an emergency department visit, especially if initial attempts at urethral catheterization are unsuccessful. This can be a complication of severe BPH, acute prostatitis, or certain neurologic conditions, and its underlying cause must be investigated after the immediate pressure is relieved. Signs of sepsis originating from a genitourinary infection represent a medical emergency. A patient with suspected acute bacterial prostatitis or pyelonephritis who presents with high fever, chills, hypotension, tachycardia, or altered mental status needs to be hospitalized immediately for intravenous antibiotics and supportive care. Urosepsis can progress rapidly and has a high mortality rate if not treated aggressively. Similarly, a disseminated gonococcal infection presenting with a triad of dermatitis, tenosynovitis, and polyarthralgia requires hospitalization and intravenous antibiotic therapy. Never underestimate a GU infection that is accompanied by systemic signs of illness. This is a clear trigger for escalation of care. Finally, any suspicion of malignancy requires a structured and timely referral process. A firm, hard nodule palpated on a digital rectal exam is highly suspicious for prostate cancer and warrants an urgent referral to urology, regardless of the PSA level. Gross hematuria, or visible blood in the urine, is another major red flag. While it can be caused by benign conditions like BPH or a UTI, it must always be worked up to rule out bladder or kidney cancer, which necessitates a urology referral for cystoscopy and imaging. Recognizing these danger zones and acting decisively is a hallmark of a safe and competent family nurse practitioner and is fundamental to protecting your patients from serious harm. Mastering the essentials of the reproductive system is, without a doubt, indispensable for the family nurse practitioner. The conditions discussed, from common STIs and BPH to life-threatening emergencies like testicular torsion and prostate cancer, are cornerstones of primary care. Your ability to accurately diagnose these issues, initiate evidence-based first-line management, and provide clear patient education directly influences patient outcomes and quality of life. The FNP stands as a trusted steward of health, navigating sensitive conversations and complex clinical presentations with skill and compassion. This stewardship is built upon a solid foundation of knowledge, allowing you to confidently manage the expected and vigilantly screen for the unexpected. The journey through a patient's reproductive health concerns is rarely linear. It requires a holistic approach that integrates physical assessment with an understanding of the psychological and social factors at play. Whether you are counseling a young man about STI prevention, reassuring an older man about his BPH symptoms, or guiding a patient through the complexities of a new ED or prostate cancer diagnosis, your role extends beyond mere prescription. It involves building rapport, fostering trust, and empowering patients to be active participants in their own healthcare. This comprehensive approach is what defines the spirit of family practice and is central to your effectiveness as a provider. The clinical pearls and danger zones highlighted throughout this essay are designed to be practical tools for your clinical decision-making. Remembering to double the PSA for a patient on finasteride, viewing ED as a potential harbinger of cardiovascular disease, or maintaining a high index of suspicion for torsion in acute scrotal pain are the kinds of clinical insights that separate novice practitioners from seasoned experts. These nuances are what ensure patient safety and optimize care. By internalizing these key points, you equip yourself not only to pass your certification exam, but, more importantly, to provide safe, high-quality care from your very first day of practice. Ultimately, excellence in managing reproductive health is a continuous process of learning and refinement. The guidelines will evolve, new treatments will emerge, and your clinical experience will deepen your understanding. However, the core principles of a thorough history, a careful physical exam, judicious use of diagnostics, and timely recognition of red flags will remain constant. By committing to a deep understanding of these foundational topics, you will be well prepared to meet the diverse reproductive health needs of your patients, ensuring they receive the thoughtful, comprehensive, and effective care they deserve from their family nurse practitioner.